Managing risk is an important element of clinical practice that both patients and practitioners need to be cognizant of. We've invited 3 RAAM clinicians to speak about their experiences in managing risk for themselves and for their patients in their daily practice.
You know, in this work, I think there are probably lots of situations that you've encountered where there's a fair amount of risk, especially for your clients. Can you maybe provide us with an example of maybe a situation where you feel that a client is at risk, and you know, what are some strategies that you employ when you encounter that situation?
I can think of one case, a very challenging, severe opiate use disorder case, you know, actively injecting fentanyl, presenting to our clinic haphazardly at best. And so significant concern at risk for overdose in this young man. And so, you know, definitely just bringing it back to the harm reduction perspective as far as risk for him. I'll talk about risk for myself as a prescriber after, but so, you know, making sure that he's always got a Narcan kit, you know, going over, you know, trying not to use alone, and so just get back to the basics of harm reduction, and educating him about, you know, tainted drug supply that's out there, the risks of fentanyl and carfentanil, and trying to engage him as much as possible. Providing safe injection supplies, those kind of things, making sure he knows he can call, you know, for support when needed. So that was kind of my approach to reducing his risk. My approach to reducing my risk was to be a little more structured and have expectations for prescribing for him. Certainly wasn't prescribing methadone because of his active injection and preferring Suboxone, and so that reduced the risk a little bit. And so, but I was still pretty structured with him because you know, even though I wanted him to be on the treatment, I needed to see him and make sure he's doing well. And so for my own risk mitigation, and he was well aware that, you know, if he wasn't going to make his appointments, at least for the outset, he probably wouldn't continue to get his prescription. And sometimes I struggle with that, and actually I should clarify that. He didn't actually always have to make his appointment, but he had to communicate with us, right? And so that's where I kind of set the boundary with him, was that we don't hear from you. I don't know if you're even taking your medication. I don't know if you are, those kind of things. But if you call and touch base with our nurse, and you say, I couldn't make it because of this or that, then I'll continue the prescription. So as long as there's some sort of clinical interaction, it can just be simple over the phone, I would continue the prescription of Suboxone so he doesn't have to get redosed and those kind of things. So he didn't actually have to physically come and see me, but I wanted to make sure that he was touching base with us. And so that was kind of how I mitigate my own risk as a prescriber, because normally I won't continue prescribing if there's no contact, because I don't know where that person is, if it's being dosed properly, if it's the right dose, those all sorts of questions that I'm not comfortable with. So that's kind of that was my approach with that one client who was, you know, pretty significant use disorder, and he was challenging for us, despite our frustrations, the whole team's frustration. And he's slowly come around. You know, went to jail for a little bit, came out of jail, was a little bit better, relapsed. I mean, pretty unfortunate, typical, you know, scenario. But he's alive, so sometimes with those people, that's a win.
Yeah, I mean, very similar. It's usually around opiate use, and has been. And one person that came in on a day when the MP wasn't there, so, but he was interested in just meeting with me to talk about the program and about possible options for treatment. And as we sort of talked more about his use, it was clear that he hadn't had any sort of harm reduction teaching whatsoever. So he didn't know about naloxone, he never had a kit. He was using alone, like he lived with somebody, but he would lock himself in his room and not. So it was like, I was really concerned for his well-being and his risk of overdosing. So we talked about all the different safety strategies, of course, right? We gave him a kit, showed him how to use it, and made sure he had one for himself and his roommate. And, we talked about Suboxone, what that was, and that he could come back and speak to the NP about that the following week. And I also connected him because he was just sort of temporarily staying with this friend, so I connected him with a community support worker to sort of also to give him another connection, but to help him around his housing piece, right? And sort of, he was very agreeable to that. And he also met with her, and then we just talked sort of about, that he would check in. Again, it was like maybe he's not going to come back on Monday, but that he'll check in with a community worker, which he did. And he's also got a counselor at the site, so we were able to sort of work with the counselor and the community worker. We feel like we've got him with some more safety strategies and some extra community support for the time being, till such a time as he feels that he's ready to begin that. So again, it's that sort of really, basic harm reduction strategies and safety around using and that we employ right away. And I find that the most risk is really, again, as I said, around the opiate use, right? So, yeah.
Yeah, I would definitely agree with Greg's approach to managing risk from a physician perspective. That's what I see our physicians trying to employ all of those strategies. And I think my role there is try to support that system in that process. And like Sheryl's experience in our clinic, really doing more of the harm reduction education and trying to really make sure that the patient understand the risk that is involved for their life as well. Mm-hmm. Because sometimes they may think that we're just trying to protect ourselves as providers, but what is the risk for you as well? Whether it's through diversion, whether it is through the missed doses and combination of this. So trying really to focus on that. And some other strategies that I do for personally for patients that there's a highly, very high risk out there. There's no way to contact them or to even find out if they didn't come back for a follow-up appointment. Are they even still alive? How would I know that? So I try to employ an approach that, especially for the very high risk and marginalized patients, a lot of the time the goals we set with the more stable patients don't work for them. Mm-hmm. So I tell them, let's not talk about goals, because for me a goal is binary, right? You either succeed or you fail. But I believe you have strength that you can still pull even in the situation and environment that you are. So why don't we create a system that works for you? So for those who don't have a phone, maybe giving them a cell phone number, because we do have our cell phones that they can, and they may not be able to write it down, they may forget. So we try to come up with kind of mnemonics that will help them remember the phone number, maybe 647 call Irene or something. Mm-hmm. So wherever you ask for a phone, you remember this, maybe easier if you need to call. The other thing is knowing that if they frequent certain shelters, are there people there that they feel safely, that they trust? Who is that person? And because we have a little bit more time, it's a matter of, do you know what their name is? Do you know the shelter? And even after they leave or while they're still there, trying to make a call there and say, I'm seeing so-and-so at Women's College. They've given me consent to talk to you, that in case something happened or we are not able to have them here in clinic, I can contact you, is that okay? And a lot of the time, believe it or not, is the social workers who work at the welfare offices who help us, because these people will go for their check. A lot of the time is where they go for the soup kitchen. Mm-hmm. And the shelter people who register them. They may just one night here at shelter. So our outreach workers do a really good job in terms of pulling those for this kind of population, but I find it really helps. And the other most important thing is pharmacies. So I am a huge fan of collaborating with pharmacists. I call them, I introduce myself to them, I give them my cell phone number. I say, instead of you faxing and calling several times to a huge department, call me. I work with all of these physicians. I am able to access the chat. Call me. But guess what? That works for them a lot of the time. But for the very first time that I need them for something, then they don't say no, and they're able to tell me, we write direction on the script, for example. I ask physician, write direction when the appointment is, and ask the pharmacist, please remind patient for their next appointment. And then I just do the work of calling. So some of those strategies, working with the teams that are supporting these people, I find for me really helps to mitigate risk.
Yeah, I mean, it really is about creating relationships, not with just with your clients, but also with your stakeholders and the other agencies that you work with, and really kind of thinking out of the box as well in terms of how do we mitigate risk for these clients, and how do I engage other organizations and other agencies in my community to sort of support them. I think that's really key. That's really great.
I think one thing that you had said, Irene, that really jumped out to me, and I think it's a very good point, is about explaining to your patients about why, as a prescriber, why you have to limit your doses, or why they can't miss a certain amount of doses. And so, again, not being too paternalistic, but incorporating the patient as part of the team, right? And so if they have an understanding where you're coming from, then there's more of a relationship there where, they can understand my risk as a prescriber about prescribing some things that may result in overdose or that need to be prescribed in a certain way. And once they gain an understanding of where I'm coming from, there's more of a relationship there. And it gets to that idea that, we've talked a lot about team, but I mean, the most important member of the team is the patient. And the patient needs to be part of the team as well. So they need to understand why things are happening. So why I have to reduce my risk in prescribing a certain way and explaining that. And I do that a lot, and I think it goes a long way.
I'll just add to that point, to the really important aspect of communication within the team. I find our team is growing, and so I as a nurse, we have the outreach workers, and I commend our physicians the fact that they kind of keep us in the loop of what's happening, what the plan is for the patient. If they reduce a dose, they let us know, this is what happened, and the patient may walk, may call, but I am reducing it for that reason, because that only allows us to be able to first advocate for the care that is being provided for the patient, and support the patient and support the physician as well. So I think that communication, even in terms of documentation, is very helpful to mitigate the risks.
Yeah, so that's a really good point. Documentation is always key, right? And in terms of minimizing any kind of risk is making sure that you document, and so that, if something does happen and there is, that you have notes and you have your documentation to rely upon. So.
Yeah.